Hi everybody, I'm Dr. Nyack. Thank you very much for taking the time to join us on our first ever live streamed seminar. This is a truly monumentous day where with the COVID-19 threat that's out there, that we're having to kind of change the way that we're running our practice. Normally we would have anywhere between 20 to 40 people in our seminar, and I'd be able to address you personally and individually, but unfortunately we're not going to be able to do that. And just for the sake of public safety, the sake of keeping you safe, and the sake of keeping the healthcare workers and everybody around us safe, we're respecting the conditions that have been placed on us to try to limit the amount of public gathering that we do. So therefore, we're doing it this way, and if this works out well, maybe we'll do this for special occasions if this turns out to be something that works out well for us. So appreciate for those of you who are taking the time to come to the seminar this way, and we encourage you to be able to ask questions. There'll be an opportunity for you to be able to do that, and then once you do have that opportunity, there'll also be a chance at the end to be able to ask questions. I'll try to answer as many of those questions as you probably have as we're going along, but nonetheless, if there's still something that you have any questions about, then again, feel free to type in your questions under the comments. And Lucia, who's back there somewhere, I don't know where. Lucia, you back here somewhere? I'm here by myself, apparently. So Lucia, our office manager, is somewhere in the premises. I don't know, hopefully this is actually coming through, and we can see that that's what's going on. But either way, we'll get started here in a little bit, and certainly we want to make sure that you understand a couple things about this seminar. Number one is that this is not a rah-rah go have surgery seminar. That is never at all how we run our practice here. What we want to do is we want to be able to make sure that you understand all the things that are necessary in the process of beginning the process of going through weight loss surgery, and more importantly, understanding the processes that got us to weight loss surgery and how we can make this a long-lasting solution for not only your weight needs, but also for overall your health. And that's really what the crux of this talk is about. It's not really about surgery. If you wait, you'll see that the amount of surgery talk we do is actually a lot less than people might think. So these are just some of my credentials. I did my first weight loss surgery in 1996 when I was in residency, and since that time I've really seen the progression of how weight loss surgery has changed from large open incisions to small open incisions to laparoscopic, and now I'm one of the first ones to do it robotically as well for selected patients. But either way, what we have seen is we've seen the results get better, but more importantly, we've also seen the safety profile improve over the course of the last 20 years. So from that end, really it's changed not only how we do the surgery, but also our understandings about what the surgery can do for us as well. And I started New Life Medical in 2014 to try to be able to give more of that support to our patients, and I think that our patients who've come through are really happy with how that we've been able to do so, and we certainly look forward to being able to do the same for you. Before we begin, there's a couple points I want you to be able to try to understand. Lucky, if you're around, if you want to stop in for a second. She's in the back over there. A couple things I wanted to address to you. Number one is the concept of the metabolic set point. What that is that where your weight is right where it's at. Your body will fight tooth and nail to try to keep that weight right where it's at. Now, it's regulated by a great deal of factors. Your GI hormones, your brain, your genetics, and of course environmental factors. All those kind of play into that. And what that means is that your weight wants to stay right where it's at. And sometimes you notice you've dropped a whole bunch of weight, but all of a sudden, boom, you're right back to where it was. That set point does change, but it changes very gradually. What your set point is different today than what it would be when you were 17, and it's going to be different when you're 65. All those things being said, you want to make sure that you're got that grasp fully in there. And there are some things we can do to change it. We'll talk about that in a minute.
I am on this computer.
All right, that's fine. So we're just saying that if you hear some typing, that's just Lucia's. That's okay. Okay, that's fine. So basically, sorry, like I said, this is the first time we're doing this, so I apologize if it's a little rough. The other one, the other concept we want to try to introduce is the concept of the body mass index. The body mass index is a calculation that's been devised to try to help compare people of different heights and different weights. For instance, Shaquille O'Neal weighs 340 pounds, but I dare say anybody would call him obese, right? Because he's 7'2" of just pure beef. Now, if you're 4'2" and you weigh 340 pounds, there's no way a frame like that could carry that much muscle. So you know pretty much the rest of it is going to end up being fat. So when you plug the numbers into the formula, it generates another number, which is the body mass index. So that body mass index is categorized, allows us to categorize and compare people of different heights and weights. So normal weight, by the way, there's no such thing as normal weight. It's considered a body mass index of about 18.5 to 25. Overweight is considered up to 30. Anything over 30 to 35 is considered obese, and that's something I want everybody to remember. When you get to 35 to 40, that number is considered severe obesity. We start seeing some problems associated with that. Anything over 40 is considered morbid obesity, and that's really the crux of the population we're really targeting with these kinds of surgeries. And anything over 50 is considered super morbid obese. So before we get any further, I want to talk a little bit about the obesity epidemic in not only the United States but also around the world. Right now, more than 2 out of 3 adults are considered to be either overweight or obese, with more than 1/3 of our population considered to have, to be obese, and 1 in 20 considered to be morbidly obese. And again, we'll talk about what that means in a minute. The scary part here is now that we're starting to see an increase, our children are starting to become heavier too, with 1/3 of our children and adolescents under the age of 17 considered to be either overweight or obese. This is a graphic looking at the obesity rates as they have changed over the course of the last 30 years when the CDC first started taking these numbers. And so when you look at these cooler blues and stuff, this is less than 15%, this is up to 20%. By the time we're getting to the turn of the century over here, we're starting to see states over here with about almost 25% of the population being obese. By the time they get this number stopped, in 2009, this particular graph, you're starting to see all these dark red states over here. That's over 30% of the population of those states is obese, with only one state left, which is up to 20%. And again, that was Colorado, and now that they've changed their laws and people get the munchies, you figure they're going to catch up. They did. So by the time you get to 2015, it's like, oh look, it's not blue, but all these red states have gotten to be, they're gone, right? Actually, no. What that means is that they actually bumped the numbers up 5. So basically what the maroon was on that last screen was up to 30, was over 30%. This is over 35% now. So basically everything's gone up about 5. So this is actually a much worse graph than what we saw previously. So basically there's no state in the union left with less than 25% obesity in the state. That number is only going up. So the question now is, what is morbid obesity? That's, remember I told you, the body mass index of 40. So basically morbid obesity is obesity that is clinically severe, where it's gotten to the point where it's starting to cause other severe medical conditions. Those are called comorbid conditions or comorbidities. We'll go over a list of some of those right now. It's also defined as a body mass index or a BMI of 40 or greater, as I mentioned, and it's also defined as 200% over the ideal body weight. For most people, that translates to about 100 pounds overweight, but it could be less depending on what your height is. Okay. Now, this may not seem like it, but this is probably the scariest thing I'm going to show you tonight. What this is a graph looking at your body mass index over here on the x-axis, and over here on the y-axis is the mortality ratio, or your risk of dying. Right. So when you look at the lowest point on this graph, which is right about here with a body mass index of about 25, that, believe it or not, is your ideal body weight. The ideal body weight is not what you're supposed to weigh. That's not what it means. The ideal body weight is actually the weight at which you will live the longest. And now once you start varying to either side of that weight, your life expectancy goes down. Your chance of dying actually goes up. Now realize you can only go down up to a certain point where you're about a BMI of 15. Because realize your liver weighs something, your skin weighs something, everything weighs something. But if you're not getting enough nutrition to be able to make your body work the way that it's supposed to, well then by golly, you're not going to end up being able to survive, and that's why there's a lower cutoff end. Now you can go up almost to the moon. And so what happens when you get to a BMI of 35? You're basically 1, 2, 3 times more likely to die at a BMI of 35 than you are at a BMI that's your ideal weight. When you get to 40, that number is 1, 2, 3, 4, 5 times more likely to die at a BMI 40 than you are at a BMI 35. And that when you get to 50 or over 50, the number is literally off the chart. And so what that tells you is the further away you get from the body mass index, or your ideal body weight, I should say, the more likely you're going to die. And if you're even further away, that number goes up exponentially. It's not in a straight line, as you can see. It actually goes up, and it gets worse the farther away you go. So morbid obesity right now is the second leading cause of preventable death in the United States behind cigarette smoking. Well, what's happening to smoking rates around the country? Well, they're going down. Less and less people are smoking, and more people are becoming obese. So more likely than not, this is probably going to end up being the number one cause of preventable death sometime in the next 10 to 15 years. So the scary part here is morbidly obese people will die 10 to 15 years earlier than their normal weighted counterparts. Think about that. That's like a decade to a decade and a half of your life lost just because of the weight. Now that's when you die. The actual effect on you may actually be for another decade prior to that. So the effect on you may actually be for 25 years. Think about it, because your knees might be bad. Your ability to get around is very limited. Your kidneys are going bad because of diabetes, or you've had a stroke because of the blood pressure. All of these things together diminish your quality of life until it gets to the point where now, 10 to 15 years earlier than everybody else, it eventually gets you. So the effect on you is actually much longer than the 10 to 15 years where it actually gets you. So that's something to bear in mind. Right now it's attributed to over 300,000 deaths a year directly attributed to being heavy, right? And think about that, that's like the population of Bakersfield dying every year just because of the weight, okay? So what are some of those other comorbidities or some of those other illnesses that we talked about that are related to obesity? Well, the two big ones are diabetes and high blood pressure. And there's probably some people watching right now with one or both of these. And these two are extremely common and fortunately are actually amenable to what we're talking about today. Cardiac disease says 15%, but I promise you that number is higher because we can't test for it effectively without doing invasive tests. Now, when we can't do invasive tests on everybody, well, we can't check, right? So certainly that number is going to be higher if we looked at more people, but again, that has complications and we try not to do that. But an easy way to think about that is this: every pound of fat that you have requires about a mile of capillary blood vessels to feed it. Well, if you're 100 pounds overweight, that's 100 miles of extra blood vessels that your heart has to pump through just to feed the fat. So these aren't regular vessels. These are little tiny capillary blood vessels that are high resistance vessels. So you have to raise a big pressure head just to be able to get the blood through these little tiny vessels. So of course you're going to end up with hypertension as part of that, right? Sleep apnea, the number that's plural is about 20%. I know for a fact that number is higher because we actually check for that very, very regularly. And so for those of you who don't know what sleep apnea is where you stop breathing at night. And the easiest way I can describe it to you is if I was to take a water balloon and hold it up in the air, it would take kind of a teardrop shape, right? Because gravity's pulling it down. If I was to set it down on a table over here, gravity would push up on the bottom and flatten out, kind of like a flattened out ball of dough. So if I have a large belly and I'm standing up, that belly weight gets pulled down by gravity, my lungs open up and I can breathe just fine. However, when I lay down to sleep, that belly weight has nowhere to go. It's going to come back down on my back, and it can't go down to my pelvis because there's a bony pelvis to hold it in place. The belly's stretched out as far as it can go. Where's it going to go? Every time I exhale, the lungs come up. It follows that weight under your rib cage. Now for me to be able to take a deep breath, I got to push against all that extra body fat, and sometimes it's too much for your body to be able to do. You stop breathing. So two things happen. Your carbon dioxide levels start going up. Your oxygen levels start going down. Carbon dioxide levels go up to the point where it triggers a reflex in your brainstem where all of a sudden you just kind of force yourself to do this loud accessory muscle breath where you're using all your neck and your chest muscles to be able to take a deep breath. And sometimes it's so violent you wake yourself up. You don't even realize you did it. I mean, sometimes you might wake up in the middle of, okay, what the heck was that? And you didn't realize what just happened. Well, you just woke yourself up from that. And this is also characterized by loud snoring. A lot of times patients are like, well, I don't snore. And the significant others will be like, oh, yes, you do. So this diagnosis is frequently made by the significant other, not by the patient themselves. And it's characterized by sleepiness during the daytime, drowsiness, just constantly feeling tired. Like, I slept 8 hours, but I'm just not refreshed. Well, it's because you probably didn't sleep 8 hours. You probably slept far less than that. You may have woken yourself 20, 30, 150 times during the course of the night. So it's impossible to get regenerative sleep when you're being woken up that many times by your inability to breathe, right? So the other thing also that's bad is that your oxygen levels are dropping. And your heart and your brain are very sensitive to changes in oxygen, so that when you end up having these little oxygen changes, it can kind of change the rhythms. Instead of this nice solid pump that gets the blood through there, all of a sudden you get this quivering, and all of a sudden if this goes in and it goes into a constant rhythm like that, where you're not doing any solid beats, you basically stop pumping effectively and you just don't wake up. So some of the people are like, oh, they died in their sleep. Well, it may have been from something like this. It can lead to arrhythmias very, very frequently. Okay. Arthritis just makes sense. The more you weigh, the faster your joints are going to wear out. Depression can be kind of a two-way street. You can be depressed because you're heavy, or heavy because you're depressed and use food as your crutch. Stress incontinence, very common in women because of the shorter urethra, that extra weight on the bladder. Every time you laugh, cough, sneeze, a little bit of urine can leak out. It's called stress incontinence when that happens. So irregular period associated also with that is polycystic ovarian syndrome, and also infertility. Extremely common in our population, because what ends up happening is that the fat cells end up producing estrogen all by themselves. Normally it's supposed to be under control, very tight control with the ovaries that are supposed to produce the estrogen, but it's under control by the pituitary, the hypothalamus, in a very tight cycle. Well, you got all this extra estrogen floating around, it's under no control, and of course it's impossible for that 28-day cycle to work when it's not getting the proper input, and of course it makes it very difficult to conceive children and even have regular periods when that happens. So that's some of them. Here's some of the other ones. One of the most important ones we're going to talk about is right over here, or DVT, or blood clots that can develop in the legs and thighs, and they can break off and go to your lungs. If it's a big enough blood clot going to your lungs, it can actually kill you. That's called a pulmonary embolus when it goes to your lungs. So that's something we take a great deal of caution with, and that's something we're going to talk about here again in the future towards the end of the talk. Sudden death, again, I told you, if you go into an arrhythmia, your heart just doesn't work, and that's really bad. Gastroesophageal reflux disease, or heartburn. There's probably a bunch of you who have heartburn. Now, I used to suffer from it. I got my problem fixed. But the good news about it is that that's something we should be able to do something about during the course of the testing, and also during the time of the surgery. So if you're a heartburn sufferer, there may be hope for you. Gallstones, very common in our population. Some of you have probably already had your gallbladder out, and we're going to check you for that beforehand, so that if you do need your gallbladder out, then we can deal with that at time of surgery. So again, infertility, polycystic ovarian syndrome. Well, guess what, fellas? The hormones are off on you as well. So when the men's hormones don't work right, things just can't work the way they're supposed to. These are all things that people don't like to talk about, but these are all things that are readily addressable by changes in lifestyle and surgery. So there's very tight associations with obesity and cancer, and as somebody who does a lot of cancer surgery also, I can tell you that these associations are very, very real. Heart failure and stroke, just some of the other things that we can see associated with being obese. So how about surgery for weight loss? For those of you who've probably been told, oh, well, why don't you just diet and exercise? That's probably most of you. And some of you have probably been able to lose weight before, right? Who's been able to lose 20, 30, 40, 50, sometimes 100 pounds beforehand? Well, at the same time, you've been able to lose that weight, but more often than not, it comes back. Well, you have to ask yourself, well, why'd the weight come back? It wasn't magic. More often than not, people just stopped doing what was working. But you have to understand, well, what were we doing that worked, and why did it stop? Well, most often when people think about losing weight, you have to think about how it got there. Well, how did it get there? Well, it didn't come on overnight, first of all. It took time, it took years for that weight to come on. However, when you think about it, when we want that weight off, when do we want that weight off? Well, we want it off right this minute, right? We want it off yesterday. So we're going to do everything we can to try to make drastic changes so that those changes can happen as quickly as possible. Oh, Dr. Nayak, I lost 30 pounds on the cabbage soup diet. Well, of course you did. Well, because you're basically starving yourself. When you look at cabbage soup, there's really not a lot of nutrition in there. And essentially what ends up happening now is your body goes into starvation mode. When it goes into starvation mode, when you're doing an extreme diet like that, two things happen. Number one, you want to stop wasting energy doing things that aren't absolutely vital to your survival. Number two, you want to conserve the energy that you already have so that you're not wasting it over time. You don't know how long, your body thinks you're in a famine or something, so you don't know how long that famine is going to last. You got to let your body energy stores last for that entire time. Well, what's the biggest store of energy in your body? Well, guess what? It's your fat. Fat is stored energy. So rather than using up all the fat, which is really what we want, it's conserving the fat, and now it's using alternate energy sources to be able to fuel the body and minimizing the amount of excess functions that we do. So what do? You stop making sperm, you stop ovulating, you stop making hair, you stop making nails, stop building muscle, with the things that we actually want to be able to do. And it does that at the expense of the proteins in your body. So it breaks down your body as opposed to breaking down just the fat. So you're breaking down muscle, you're stopping all these other things that you need to be able to do for normal life functions at the expense of conserving fat, because you want to be able to conserve that fat as long as possible. So as you're losing weight, you're losing 15, 20, 30 pounds. Say your goal was 30 pounds. What happens when people make their goal? Well, they celebrate, right? Yay, okay, I made my 30 pounds. What's the first thing you do? You go back to doing what you did before, because hey, I've been denying myself for all these months. I'm going to go straight back to doing that. I've deserved it. I've earned it, right? Well, so if you go to a buffet or whatever the case is, or have a piece of pie, whatever the case might be, the body's now like, okay, well, you know what? All these extreme things that were happening, it's over. The famine is finished. Oh gosh, all right, the floodgates are open. Okay, we can finally start getting back to normal. However, this may happen again. So you know what? Why don't we do this? Let's not go back and build our muscle and everything else back. Let's build our fat stores back first so that we can actually go ahead and survive it if it happens again. So here you lost your 30 pounds, right? So you built back your fat stores where they needed to be. And now once you're at that point, now you can go back and start building what you lost. So more often than not, what ended up happening is you lost 30, but then you ended up gaining 35. You're like, whoa, what just happened? I just gained more weight than before I started my diet. You know what? I'm just going to do it again. So more people than not say, okay, you know what, I'm going to do this second time. People tend not to be as motivated the second time they do something as they were the first time they do it. So instead of waiting until you got to full 35, I'll be like, hey, I lost 25, good enough. Go back to doing what you're doing before. And all of a sudden you put on 30 or whatever the case is. And so this pattern is called a yo-yo dieting. And just about every single person who's come in through my door has been a victim to this. And as you can see, the general trend is always up. It doesn't work, which is why it's so frustrating, because people feel like they've been able to do it, but then in the long term just can't keep that weight off, which is why it doesn't work, and it ends up working against you in many ways. So like I said, most people focus on crash diets when that happens. And a lot of people say, you know what, I could do this. I just need a little help. And that's really where lifestyle modification and everything else really comes in, and we're going to talk about that. And surgery can be that help for appropriate patients. Surgery is both safe and effective, and the overall benefits of surgery are going to outweigh the risks of surgery, and also going to outweigh the risks of remaining morbidly obese. And so if it didn't work, or if it was totally unsafe, we wouldn't be doing it. And so far we found that we can do both, right? So why surgery though for weight loss, right? You've been told diet and exercise. We can see that some people have been able to get that off. Well, we have to think about it in a little bit different terms. There's diet and exercise, there's diet versus exercise. There's foods we should be eating, let's be honest, we know that. And right now exercise just isn't a part of our lives like it used to be. So why is this caveman here? I want everybody to think back 10,000 years ago. How did we get our food 10,000 years ago? Did we just go to Vons or call Uber Eats? So right now that's a problem because of all the stuff that's going on. No, you had to go out and get it, right? You had to go and climb up a tree, pick it, dig it out of the ground, or go chase it, right? Chase down, kill it, drag it back to wherever the cave or hut we were living at the time. And it wasn't called exercise back then. What was it called? Well, it was survival. If you didn't do it, you didn't eat. Plain and simple. We don't have to worry about any of those things today, right? We can just call one of those services and they'll put that, right on our lap. Call Domino's and they'll deliver it right to our door. 30 minutes or less, or it's free, right? I took advantage of that in college, but anyway, we won't go there. The point is that one pizza they had sitting on your lap is more calories than the caveman would have had in 10,000 years ago in a week, and we just ate the whole thing. And physically, we didn't have to lift a finger really to earn that. Overall, what's happening is that if you look at how we get our food and the quality of the food that's out right now, this is the most calorically dense food that's ever existed in the history of mankind. One bite of food today is more calorically dense than it ever has been. And we're having to do less and less to get that food into our systems, okay? So, well, how is that? Why is that? Well, I want everybody to think back, again, and 10,000 years ago, if you wanted to move anything, you want to get anywhere, basically you had to drag it with you, right? And then we got smart, we tamed the horse, and now we're able to get that a little bit further away. We can explore further resources. But, we still can't take everything, so we got the wheel now, we've got a wheelbarrow, we've got, horse and buggy, we can take all of our belongings, move to a place where our resources are more available. And so horses are expensive. They can go up lame. They can get cholera and die. Bad things can happen to your horses. So that's not meant for everybody. Not everybody's able to afford one. But one of the things that people don't realize is that the bicycle doesn't seem like it, but that was a major invention. If you go back to like the National Geographic specials back in the day, you look at India, China, and some other third world countries, right? It was a sea of bicycles. It wasn't a sea of automobiles. And so what you end up seeing was that you still were using your own personal power to be able to move yourself. Okay, the real game changer was the automobile. As long as you can afford gas, you can pretty much get wherever you wanted to. And now you're taking the personal aspect of it out. Even though a horse is doing all the work, if you've ever taken care of a horse, that's a lot of physical work. Well, you don't have to really do that with an automobile now, right? So that stepped up even further now once we have the airplane. Now we can get to other parts of the world in just a matter of a few hours. Pretty soon we're going to be going to other star systems, or we can just teleport to where we want to go. We're not quite there yet, but at some point maybe we will be. Okay? So the National Institutes of Health sat down in the early 1990s and said, okay, who's going to be a candidate for a weight loss operation like this? And they set up some criteria. First of all, what they said was surgery is a tool. Notice, this word is not cure. Okay? I want you to think back to some of the people that you know in your circles that have had weight loss surgery before. And if I was to poll the audience and say, okay, fine, of the people that you know who've had weight loss surgery before, how many of those do you know that have gained their weight back? Just about everybody in the audience ends up raising their hand and saying they know somebody who's gained their weight back. Well, why is that? Well, more often than not, it's not because the surgery stopped working, it's because they kind of went back to the way they were living before. And we'll talk about that a little bit more aggressively here shortly. But again, it's not the cure. If you use a tool correctly, it works the way it's supposed to. However, if you don't, well, it can't do what you planned it for it to do. So surgery is a tool that can provide consistent, permanent weight loss for morbidly obese patients when permanent lifestyle change guidelines are followed. Not temporary, but permanent. If it wasn't working for you before, it's not going to work for you after surgery. We really have to take stock in the things that we're doing to figure out, okay, how can we change those things? And it takes a lot of behavioral truth. We really have to look carefully at the things that we're doing in our lives to make sure that we make those healthy changes. We're going to guide you through that process as we go along, right? So it also says here that surgery is appropriate for motivated patients. Patients like, doc, I really don't want to do anything you're telling me. I just want to have the surgery and I'll get thin. It's not how it works, as evidenced by the number of people who are going to raise their hand who know someone who's had weight loss surgery before. Also, it's about having a multidisciplinary team approach. It's not just somebody saying, hey, I'm just going to have surgery and, or you're going to your surgeon and say, okay, yeah, go have surgery, we operate on you, and that's the end of it. No, we're going to have a whole team of people that's going to be looking at you. It's going to be a whole team of people that's going to be guiding you, and a whole team of people that's going to be supporting you. That includes a psychologist, it includes a nutritionist, it includes a physical therapist, your bariatric coordinator, your primary care physician, and most importantly, you as the most important member of that team. I'm the last guy that you're going to see. And basically what that means is after everything is checked out, after everyone's given us their okay, says, yes, this is going to be a good candidate, then we can move forward with surgery. Okay? Surgery is also indicated for patients with a body mass index of 40 or greater, also with a body mass index of 35 to 40, which is severe obesity, and significant comorbidities associated with that. So what comorbidities are those? The main three that will qualify you if your BMI is not quite 40 are diabetes, high blood pressure, and sleep apnea. Any one of those three will qualify if your BMI is between 35 to 40. And also finally, documented dietary attempts have been ineffective. So basically, what that means is you're going to have to talk to your primary care doc or through our office. We can help work with you on that and say, look, I've known this patient for so many years and so on and so forth, and we've gone through this program, and none of them worked, and they'll be able to generate a letter that's going to help support your case for approval, and we'll walk you through that process as well. Okay, so our criteria, first of all, you got to meet the criteria we just talked about. You have to meet insurance criteria. The various payers are going to have several things they're going to want you to do before they will approve the surgery, and we have a full list of what those things are so that we can help guide you through that process and make sure we have all of our I's dotted and T's crossed. Can't have an endocrine cause of obesity. For instance, your thyroid just flat out doesn't work, and all we really have to do is just fix your thyroid problem. and so it may not need an operation. And I've said numerous times over the years, the best weight loss operation is the one you never need. So if you're one of those people that have never been through a medically supervised program, well, let's start there, and certainly a combination of those things can get you where you need to be. And we do work with several physicians in town that are able to help us with that process, right? So absence of a drug or alcohol problem, it's hard enough making one significant life change. Well, let's stop the things included in there should also be cigarette smoking. These are the things that are killing you faster than your weight. Let's work on trying to get you healthy, both body and mind, before we can think about getting you to another life-changing event. Let's get you where you need to be first, okay? And no uncontrolled psychological conditions. For instance, say you use food as your crutch. Well, I just took away your food crutch by doing a weight loss surgery on you. Well, how are you going to respond the next time you have a stressful event? So it's really, really important to make sure that a couple things happen. Number one, you will see a psychologist during this process. Be very open and honest with that psychologist, because sometimes there's going to be things in your past that you may have had trouble talking to people about in open settings to be able to get the support that you need. Talk to them, because if you need to talk to somebody to get some of those issues out, frequently it's an abuse issue, whether it's sexual abuse, bullying, physical abuse, emotional abuse, other types. Basically, these are things that can affect you going forward in your life, and if you're not addressing some of those deep-seated issues, then no matter what surgery we do, we're not going to be able to do that. So we want you to be in a healthy place in every way, and we want you to get through those things, at least have a healthy support system available to you. The other way that support will help you is because you want to make sure that everybody around you is supportive of your decision. You really need to have a very open and honest talk with them to make sure they're not doing anything to sabotage you, or really you're not doing anything to kind of make it hard for you to be successful. For instance, every now and then I'll hear somebody say, oh, I'm trying to eat healthy, but my significant other always brings home like Cheetos and ice cream and that kind of stuff. Well, if it's in the house, you're going to eat it, and I'll tell you about that later. But the fact is that if they're not willing to make some of those changes with you, and chances are they can probably stand to be a little healthier themselves, then it's going to make it harder for you to do that. You can't have somebody flaunting, something that we're telling you not to do right in front of you, because eventually you're going to do that. Somebody's trying to quit smoking cigarettes, but everybody in the house is blowing smoke at them. It's going to make it extremely difficult to do that. You almost have to do this together. You need to have a nice core of people around you that are willing to make some changes with you, and not make you feel guilty about doing something healthy for yourself. So really have that open and honest discussion with the people around you. All the team members have to agree that it's going to be a good candidate for surgery. And so we'll do everything we can to make sure that if anybody has any objections, say, hey, there's a couple things we want to work on. Okay, well, let's work on those things. Okay, let's get you in the best place you can be so that everybody's ready. I'm in no rush to do anything. I want to do this when it's ready for everyone. I want you to be in the best condition you can be. Like I said, be well prepared to make these changes. And so, like I said, I'm a patient person when it comes to this. A lot of the insurances make you wait up to 6 months. Well, if it takes a year, it takes a year. That's okay. I'm in no rush, but I want to do it when it's right. Most people, by the time 6 months, really get it and really are ready for it by that time. Okay, so most patients have to be dedicated to permanent lifestyle change, guidelines, and follow-up. Like I said, that includes going to support group. There is so much data to show that patients who go to support group do much better than patients who do not go to support group. And we have several active support groups here in town that are open to the public. Whether you had surgery elsewhere, it doesn't matter. Find that support group. We have lists of all of them, and we can get you involved in them if you like. And more importantly, though, be there. There's different topics every month, and they're usually moderated by professionals, so it's not like just being in some chat room, somebody's just saying all kinds of crazy things that are, either untrue or, you're trolling somebody or whatever. There's something to be said for being live, in person, with some accountability for the people in front of you. So that's why I'm a real big fan of actual in-person live support groups. I think they work better. Okay, keeping your appointments. I want to see you back. I can't help you if I don't know there's a problem. And I follow you back a lot more closely than most other surgeons' offices do. You might see me and my PA, Steve. I haven't mentioned Steve, my PA. He's excellent. He's been doing this with me for several years now and really knows this process in and out. And he's a very supportive individual. And so right now, Steve's doing telemedicine because he's at a high risk for infection. So we'll still be able to get Steve involved. But some of that's going to be by telemedicine, but we'll get you in on that as the time comes. Hopefully that won't last for too much longer. Okay, so again, it's not like over the hill see billboards for this. They want you to go over there to go get your surgery. Well, guess what? We want to see you back. It's very hard to do that when you're having to drive 3 hours to go see your surgeon. We want to make sure that you're available, and that we're available for you any chance that that you need us. Okay. And also, and there's daily, regular exercise, right? How many people here have time to exercise every day? Well, everybody's like, oh, I got to go to work. I got kids to take care of. I got this to do. Well, the thing is that most people actually do have the time to exercise. We just choose not to do it. We choose to fill our time up with other things. So if you don't think so, I'll tell you. I'll make 5 hours for you right off the bat. So when you go home, well, you're probably home right now, don't just turn your TV off, unplug it. And you're gonna find you have 5 extra hours. Most Americans end up watching about 5 hours of television a day. And so if you're bored and you're like, oh, I'm bored, well, you probably have time to exercise. You just have to prioritize that and make it a thing to do. But if you're one of those people that just has to watch a show, well, if you have a treadmill, most people do, it's sitting in the garage acting like as a coat rack. Pull it back into your living room, and if you got to watch a show, watch it from the treadmill. At least you're moving, right? So watching Walking Dead while you're walking makes a little more sense, right? Instead of doing it on the couch. So if you really want to, there's ways to kill 2 birds with 1 stone, as opposed to having to find an hour to exercise and an hour to find Walking Dead, or to watch Walking Dead. So make sure that you're trying to be more efficient with that, and you're going to find that you can do these things a lot more effectively. For those of you who aren't real big TV watchers, well, guess what? I'll make 2 hours for you. When you get, after this is done, not before that, go and unplug your internet router. Most people spend about 2 hours a day on social media. If you're going to be doing that, this is a good place to be doing it, so I'm not going to knock you on that. But in general, though, that social media takes up a lot more of your time. So again, find ways to be more efficient with your time use. So, support groups, keeping appointments, daily regular exercise, and also dietary changes, right? Everybody knows there's stuff that we're eating that we probably shouldn't be eating. And so Oreos were the bane of my existence for a long time. When I first got to Bakersfield, I was a big boy. I was a lot heavier. And so during the course of residency, you know, I was exercising less. I was always athletic and always doing some kind of sporting activity. But that stopped when I was in residency. I just didn't have the time. I was really working about 110, 120 hours a week, right? Regularly spending 3 to 4 nights a week in the hospital. It was very, very brutal. So by the time I got here, I'm thinking, okay, yeah, I'll have time to take care of myself. But it turns out I was working just as hard here as I was back in residency. I'm a single guy. I kick up my feet. I want to turn on ESPN when I get home at 10 o'clock. I don't cook. So what's a nice comfort food? Well, Oreos seem to fit the bill, right? And so I'm a smart guy. I can read the package a little bit. I look at the package, it's 175 calories. Yeah, but how many cookies is that? 2 cookies. Who eats 2 Oreos? Nobody eats 2 Oreos. Did I eat 1 row, 1.5 rows, 2 rows? By the time I finished eating 2 rows, I didn't get 175 calories. I got 1,750 calories. That's half a pound of fat right there. It takes 3,500 calories to make a pound of fat. So I'm halfway there, and of course that doesn't count the milk you drink with, right? Of course, it does the body good. We're going to talk about that, right? So this is just an example. I'm not, everything I'm telling you, I'm saying as a person on your side of it. I'm jealous you guys are all going to have some help. I didn't have any help. It's a constant struggle for me, just like it is for you every day, okay? But in all fairness, we're set up to fail. When you look at the dinner plates from the 1950s and 60s, you compare the dinner plates now, they are massive. And study after study has shown that if I put the same amount of food on this plate as I do on this plate, the first impression, you guys are like, hey, where's all the food? Your first impression is to fill it up. And of course, ever since you're a kid, you're all been told, finish your plate. Okay, so you're forced now to be able to eat more food. You look at the dinner plates in an American restaurant, the average American home a little bit smaller. And in Europe, much smaller. So again, you're starting to see how, as a society, we're bigger than they are around the world, partly because of something like this. So in the late 70s, early 80s, everybody was dropping dead of a heart attack. This is a Time magazine cover I remember because I used to get that when I was a kid, so I downloaded this. But the point is that everybody's dropping dead of a heart attack. And so when you did an autopsy on somebody who died of a heart attack and you looked at the coronary arteries, which are the arteries that go to your heart, should be nice and smooth and open, they were filled with these cholesterol plaques, right? They look at them and they're like, oh gosh, they're filling with cholesterol, they're blocking the arteries. Obviously cholesterol is the problem, right? Well, it turns out the association with cholesterol, what does people associate cholesterol with? With fat, right? So sure enough, they say, okay, fine, stop eating cholesterol, stop eating fat, go on a low-fat diet. That should reverse all this or prevent that. Well, we started doing that in the 80s. Remember margarine? Margarine is like the worst thing you do for yourself. But the point is that not only did we not see the heart rate, the heart disease numbers go down significantly, we also saw our obesity rates going up. Because when you start taking the fat and cholesterol out of food, what does it taste like? It tastes pretty bad. So what do people replace it with? They replace it with sugar. that's essentially what was now in our food. And so as it turns out, a lot of the data here about the fat being removed from being the problem with heart disease actually was supported by the sugar industry. The sugar industry actually paid reputed scientists to publish false studies pinning cholesterol and fat as the problem for the heart disease epidemic. Well, it turns out the biggest reason why everybody was dropping dead of a heart attack is because everybody was smoking back then. And so now with less and less people smoking, the heart disease rates haven't really changed because now we're getting all this extra sugar. And so let me explain that to you in a little bit different way. Is sugar going to kill you? Well, sugar is immediate use energy. Okay, so think about it this way. What does a hummingbird eat? Well, hummingbirds eat sugar water. Has anybody ever seen an obese hummingbird? No, because their metabolisms are so fast they're zipping around 8 million miles an hour, they burn it off no sooner than they get it. However, I'm not that active, you're not that active. None of us can work that quickly to be able to burn off all that sugar. So sugar is also very, very hard to find in nature. What are some natural sources of sugar? Well, think about it. The easiest one is fruit, right? Fruit's a very easy source of sugar, but when is fruit available? It's not available year-round. It's only available when it's in season. What's another source? Honey, right? Honey's hard to get unless you're brave enough to raid a beehive, okay? Well, most people aren't going to do that. Other sources of sugar are usually complex carbohydrates, things like tubers, like potatoes, these kinds of, you have to dig them out of the ground. It's not easy to get those either. And even then, only when they're growing. So when you look at sugar, your body is not used to getting that if you look at 10,000 years ago in our diets. So what happens with all this sugar? Now we got this big load of sugar in our bloodstream. The blood sugars go up, and so we absorb it. Our bodies are trained to get and absorb as sugar as easily as possible because that's like free energy for your body. It's immediate use energy. So now you've got these sugar molecules in your cells, but you're not doing anything. We're sitting down and watch TV, or we're typing on our computer, whatever the case might be. So the cells are like, hey, we got all this extra sugar. We don't really want to let it go to waste. What are we going to do with it? So your body ends up storing that sugar. And what does it store it as? As fat. Right? So that cholesterol being elevated, turns out the middle step in storing sugar to fat is actually cholesterol. So when you have a high sugar load, your cholesterol goes up, your fat levels go up. And so some of the cholesterol, in everybody's defense, some of that is genetic. Probably about half of it is genetic. So the rest of it can be manipulated with dietary changes, right? So I'm not saying that eating fruit is bad for you. The reason I'm saying bringing fruit up in the first place is because we don't eat fruit the way we're supposed to eat fruit. And I want to explain that a little better. Go back 10,000 years ago, like I said. When was fruit available? It wasn't available year-round, right? It was only available in season. That was usually late summer, fall. The spring blooms happen, the fruit sets, and the fruits grow and ripen over the course of the summer. So that by the time late fall happens, now you've got a tree full of ripe fruit. Here's your band of, cave people walking around. You're like, hey, look, a ripe tree. You go there and you pick all the fruit. And you pick that clean, and then next you go down, a few hundred yards, you find another tree. You pick that one clean. So you got all this extra sugar now that you've got in your system. Do you think these people are going to get gain weight? Do you think they're going to get fat? Yeah, they are. And you know what? It's totally okay for them. And the reason for that is because they're getting all these extra sugar calories right now. But guess what coming after that? Winter. Well, in winter, you're not going to eat for 6 months. And so you have to live off those fat stores because you're not going to get this kind of food again for another year. And who knows what you're going to be able to find during the course of the winter, right? So we don't have that problem, right? If it's out of season here in our part of the world, we just ship it up from South America or wherever the heck it's in season from. If you go to the grocery store right now, you'll see the fruit out. Well, maybe not right this minute, but in general, you go there, the fruit aisle's full, right? It's all stuff that's not growing outside right now. Is all stuff that's being brought in from elsewhere where these fruits are in season. So again, it's not that eating fruit is bad. It's just we don't eat it the way we were meant to eat it. So you have to take everything with a grain of salt when it comes to that. Okay. So what about other dietary changes? Milk, right? It does the body good. It's good for you, isn't it? Well, we've seen ads like this for the last 20, 30 years where we see a beautiful model or we see a buff athlete, they put a milk mustache on them. Subconsciously, you think, okay, if I drink milk, I'm going to look like them. Well, guess what? They get paid to look like this. A couple things about milk. What's milk for? Well, I'll tell you, it's for babies. The purpose of milk is to make a little tiny baby as big and as fat as quick as possible. That's why you see these 6-month-old, breastfed babies just got rolls all over the place. You just want to eat them. But at the same time, really what it comes down to is that we're not meant to be doing that. We're the only animal on the planet that drinks milk as an adult. We're also the only animal on the planet that drinks milk, another animal's milk. What part of any of that makes sense to you? Well, it's not, because we have a very powerful dairy lobby that has worked its wonders with great advertising campaigns to tell us that that's what we need to do. The other thing about milk is how much sugar is in milk, right? Anybody heard of lactose? Anything that ends in OSE is actually a sugar. There's actually a large amount of sugar in milk. And so again, this is just yet another reason why you don't realize all the sugar that you're getting. For instance, a can of regular Coke, 12 teaspoons of sugar in a can of Coke. That's all sugar that you just don't need. Bread, rice, pasta, potatoes, beans even. Most of those things fall in this category. What do they all have in common? Well, that's starch. Starch is sugar. These are glucose molecules that have been linked in the chain so that when it's in that form, it doesn't taste sweet, but as you absorb it and break it down, it is sugar. Some of it's a little slower to be absorbed, which is a little bit better for you as opposed to table sugar and other simple sugars. But the point is, in the end, that sugar's got to go somewhere, and it's either going to get burned off or it's going to stay on board. Okay, so read your package labels, really learn how to do that. We'll help guide you through that process, and then you'll realize ain't nothing lean about a lean cuisine. Yes, they cut the fat out, but you got to see how much sugar is actually in there. So the whole concept of low-fat diets and that fat is bad, that's a total misnomer because it was based on false science. The other thing also that you don't realize about fat is that you tend to eat less with a fatty meal. That fat sits in your stomach. It's actually much harder for your body to digest fat than it is sugar. Sugar absorbs very quickly because, again, like I said, your body's really wired to do that. You actually have
Diet Cokes.
Oh, so the question was about Diet Coke. Well, the jury's out about that. We don't really know whether or not Diet Coke is any better for you or not. There's actually data to show that the fact that it's sweet still tricks your brain into thinking that's what it is. So some of the same metabolic responses you get to sugar still end up happening with Diet Coke too. So best thing to do is just wean yourself off of all of those kinds of things, and that'll probably be the best answer for you. Right? But again, in all honesty, artificial sweeteners, the jury's out on them. A couple things I know for sure are bad. Aspartame, that's NutraSweet. That's the one in the blue packet. The other one is saccharin. That's the one in the pink packet. If you're going to have an artificial sweetener, the two I would recommend you do, stevia, that's a little more natural, and also Splenda, which is the one in the yellow packet. Stevia is in the green. So between those two, that's what I would stick to if you have to use an artificial sweetener. Okay? So between the low-fat diets, again, the idea that fat is bad and is going to make you lose weight, more often than not, when people are on a low-fat diet, they end up gaining weight. It's not the other way around. Look at our society since we started telling people low-fat diets. I'm not saying an eat a pound of lard is a good idea. That's not at all the case. But what I'm saying is that a proportional amount of fat with a decreased carbohydrate load is probably the thing that's going to help you more than anything else. And again, like I said, you end up eating less with fat, and the other thing also is that you end up burning calories because it's very hard for you to digest that. Okay, this is the aisle you probably ought to stay away from at the grocery store. It's nothing but chips and soda and all the other things that we told you are probably going to end up sabotaging your overall efforts. Now, one of the things also that's interesting about sugar, remember I told you we're wired to want sugar because it's very hard to get. That makes it very addictive. This is a functional PET-CT looking at the pleasure centers of your brain. Sugar actually affects the pleasure centers of your brain more than cocaine does. So you can imagine how hard it is to just give this stuff up. It's really, really difficult to do so. One of the other things also that's even worse than sugar is something called high fructose corn syrup. Let me tell you, it's not corn syrup. What this is a chemical that's been derived from corn syrup that is probably one of the nastiest things you can put in your body. It is more addictive than sugar, and the other thing also that it does is it's so potent that what it does is it actually ends up shutting down your pancreas's ability to really modulate the insulin response, so it makes it very insulin resistant, making it hard for you to regulate your own blood sugar. The other thing also is actually a very pro-inflammatory agent. There's a lot of data now to show that a lot of the medical conditions that we deal with on a daily basis are actually related to increased inflammation in the body. Well, high fructose corn syrup is one of those things that actually will throw that way through the roof. And so it's so bad for you that it's actually banned in 90% of the world, but not in the U.S. because we got to make the corn farmers happy. We got to keep somebody happy. The lobbies have really kind of done a number on us between milk and this, and again, like I said, we've got to kind of just step back for a second. The truth is right in front of us. We have a veil in front of us that's been painted on there really, really well. All you have to do is lift that up. And now we can see that really you're set up to fail. So as long as you are armed with the knowledge of what's going on here, we're going to do what we can to try to teach you as much as we can about this. You'll realize making some of these changes isn't that hard. And more importantly, though, we're going to guide you in that process. Okay? Now, for those of you who are diabetic, I'm going to put diabetes to you in a super, super simple manner. Maybe you've never even heard it spoken like this. Well, diabetes is basically where your pancreas is saying, okay, fine, you know what? For years, whether it be from disease, whether it be from excess sugar use, genetic reasons, whatever the case might be, at some point your pancreas just gives out and says, okay, you know what? I can only give you this much. Anything beyond that sugar load, your blood sugars are going to go high. And an increased blood sugar is what causes all the problems related to diabetes, the nerve damage, the blood vessel disease, all these other things, the infection risk, because of having an elevated blood sugar, right? So your body's telling you, I can only give you this much. Now you've had a meal, your blood sugars are up here, okay? Well, there's two ways to get your blood sugar back down to a healthier level. Number one, we'll put you on medication, right? So there's several different kinds of medication that are out there. The one that's popular out there right now is this new class that actually poisons your kidneys so that you can't reabsorb the sugar in your bloodstream, so you end up peeing it out. Well, your blood sugar is going to go down, everything's fine. Well, what about the side effects? We're concentrating primarily on the main effect, which is decreasing blood sugar. What about the side effects? Well, let's think about this. You're actually getting a bunch of sugar now in your urine. That's free food for bacteria now. So you should see the list of bladder infections, kidney infections, yeast infections, all these other things that you never had before. And so the other thing also is that it forces your urine to become more concentrated, so your body then puts more fluid in it to try to even it out, so the osmotic shifts aren't as severe in your body, and you end up getting super dehydrated. So that's one of the more common things that happens with it. And this is just in the short term. We don't even know what this is going to do for long term. These medications have only been out for less than 10 years. So again, these are things we have to really pay attention to. How about other medications like insulin, metformin, all these other things? Well, you're not peeing that sugar out, right? So that sugar came down, but you didn't pee it out. So where did the sugar go? Did it just magically disappear? No, it's still there. Basically, what it does is it tricks your body into absorbing it into your cells. Well, what happens to cells that have a bunch of extra sugar in it? Where does that sugar go? It gets stored. So you're like, hey, my blood sugars are really good. I'm really good. Yeah, but I put on 15 pounds. What's that all about? So again, that's a very simplistic way of looking at it, but it just makes sense to say it's like, that sugar has got to go someplace, and it's really important to understand that. Well, that's option one. Option two is this. If your body's telling you, I can only handle this much sugar, why on earth are you giving it this much sugar? If you decrease your actual sugar intake to something your body can manage more, there's no reason to be able to have to do those things. You don't need to be on those medications. You're not going to need to have all these other disease processes. Now, I'm not saying that's the case for everybody, but at the very least, you can control that a lot more than you think. So again, it's really important to make sure that you pay attention to your sugar intake. So one of the things, what I really espouse for my patients is a lower carbohydrate, especially simple sugars and refined sugars, and higher natural protein and natural fat type diet. Some examples of that are Atkins, South Beach, Paleo, and the one that's really popular right now is the keto diet. And the keto diet, I always tell you to kind of take it with a grain of salt, because if you already have cholesterol issues, that can exacerbate those problems, so it's something you have to really do carefully. And again, there are people we consult with that can help with that. For most people, though, these are actually very doable diets, and certainly it's something I want you to be able to try to accomplish before we do surgery, because this is how I'm going to want you to eat after surgery. So for those of you who have not had an opportunity to actually investigate it, get a copy of each of them. I read them all, and I kind of practice a hybrid of all of those. So going back to when I first got to town 20 almost years ago, I was a big boy, and I said, I'm like, you know what, this has got to stop. Everybody reaches their point where like, I can't do this anymore. They reach that come to Jesus moment, like, I got to change some things. And what I found is that the things that I was taught in medical school and residency, they didn't just quite make sense. So I did a lot of research on my own to try to figure out what was going to work, and that's when I discovered Atkins. And I went on Atkins for 2 months. I didn't lose a single pound though. I was like, oh, what's going on? Well, as it turns out, I was cheating left and right. Well, the Nyack version of the Atkins diet didn't work. So I actually went and, instead of skimming the book and said, yeah, I know this, I know that, which I did, I skimmed the book. I actually read it. I read it as though I didn't know anything else about it. It turns out I didn't, because I actually learned a lot by reading it the way I was supposed to. And actually started doing the diet the way I was supposed to. And so imagine that. When you actually do what they tell you, it works. Go figure. Now, mind you, it didn't come off overnight. It took me about 9 months to lose about 40 to 50 pounds, somewhere in that range. and I've kept that off now for the majority of about 20 years now. So the important thing about that was this, is that I was cheating left and right because it was in my house, right? So instead of having a big bowl of Crunch Berries before I went to bed, I'd have a little bowl of Crunch Berries. Instead of having 2 dinner rolls, I'd have half a dinner roll, whatever the case is. So I went through my kitchen, I went through the cupboards, the freezer, everything, and got rid of everything that was not on the diet and restocked myself with everything that was. And guess what? If you make better choices, you're probably going to make better decisions, right? If you set yourself up for that, then that's what you're going to do, right? People tell me, oh, I'm trying to quit smoking. Okay, well, don't buy cigarettes. If you don't have cigarettes, you won't smoke them. So smoke them if you got them, right? Well, don't smoke them if you don't got them. It's the same idea. If your house is full of the things that you know you're not supposed to be eating, that's what you're going to eat. So you have to make that decision not with the dinner table. These decisions begin at the grocery store. So make sure that you're starting to make better choices about that, and you'll be fine. The other thing also is people don't realize how much sugar is actually in their food. So if everybody can do this, go to calorieking.com. It's a free website. You can go straight to your web browser. Or now that you used to have it only in the Apple App Store, but now they have it in the Google Play Store. So if you have an Android phone or an iPhone, you can go to the app stores there and download the Calorie King app. It's got a little magnifying glass on it. You'll see it's a free app. And it'll give you this search bar. Type in whatever food you want, and it'll be able to break it down for you by serving size, by cup, bowl, spoon, whatever the case might be, and you can adjust that, and it'll break it down by calories, protein, fat, and carbohydrates, right? What you want to do is really take a good look at the amount of carbohydrates you're taking. The general rule I try to apply for my patients is this. You may want to write this down also, is 50 grams or less of total carbohydrates per day, and 75 grams or more of protein, right? If you don't know how much is in your food, there's no way for you to do that. For instance, a bowl of oatmeal, right? Most people end up eating oatmeal in the morning because it's good for your heart, good for your cholesterol, these kinds of things. What people don't realize for that is a plain bowl of oatmeal, put it in the Calorie King, what are you going to find? A bowl of oatmeal, 55 grams of carbohydrate. How many did I want you on for the day? 50 or less. So I already blew it with 1 bowl of oatmeal. How do you like that? So that's just plain oatmeal. So what does plain oatmeal taste like? It's disgusting. The 2 most common answers I get at seminar are number 1 is cardboard, number 2 is crap. So it's probably what you're thinking. But the important thing is, how do we make it taste better then, right? Brown sugar, put a little bit of butter in it, put a little bit of cinnamon, and put a little bit of fruit in there, right? So how about America's favorite fruit, the banana? One large banana, 31 grams of carbohydrates. So by the time you left the house, you got your bowl of oatmeal with a banana in it, you already blew it, right? You're over 80 grams of carbs for the day when I wanted you on 50 or less. If you don't know what's in your food, you can't make better decisions. That's why I encourage everybody to look everything through here, and you're going to find you'll have a much better way of being able to make better decisions, right? So going back to this, support groups, keeping appointments, daily regular exercise, and dietary changes, okay? So let's talk about surgery now. Basically, there's 2 major classes of surgery. Number 1 is the restrictive operations, which basically change how your stomach perceives food or how much food your stomach can hold. An example of that is the gastric band or the lap band, and also an example of that is the gastric sleeve. The other class is a malabsorptive operation, where basically you're shortening the intestinal tract so you don't absorb the calories that you take in. Example of that is the duodenal switch operation. Though there is a restrictive component, though not as much. So basically, a hybrid of the 2, where you're decreasing the amount of food you can fit and some malabsorption, is the Roux-en-Y gastric bypass. And again, we're going to talk about each of these operations in a little more detail here in just a minute. So when you're looking at the lap band has been around since 2005. I was one of the first surgeons in California to start doing them, and I really thought it had a good place in our practice because it wasn't as extreme, right? This was probably one of the least minimally invasive operations we could do and still help you be able to lose weight. Of note, all the operations I perform here are either laparoscopic or robotic, and very rarely do we have to change that. Okay, so how does the lap band work? Basically what happens is, if you've ever seen or know anything about it, there's a silicone band that goes around the top part of the stomach over here, and it's got these balloons on the inside of it. So that band goes around the top part, it's connected to this tubing to a little port that goes underneath the skin, and it's connected all there. And what ends up happening is, after we attach that port, I can go ahead and inject that port with saline to either tighten or loosen the band depending on what we're trying to do, and we adjust it and tailor it to according to weight loss needs depending on what your personal situation is. We can loosen if it's too tight, we can tighten if it's too loose, and again, everything works out well. The thing that people liked about this the most is right here, the word reversible. And it kind of begged the question though, because why would you reverse it unless there was a problem? And I really love the concept of it. So this is an example of an improperly adjusted band. So food goes here to the top and it slowly trickles down. The nice thing about it is that as this stretches out over here, you feel fuller, longer, faster. And then what happens as the food trickles down there, you end up absorbing your food naturally. You're not reabsorbing, you're not rearranging your intestinal tract, you're not cutting anything, you're not stapling anything. And again, if we, barring some of the weirder problems, we can remove that band and get you right back almost to where you started, right? So again, what it did though was beg the question of why would you take the band out unless there was a problem? Well, what I found is over the years is that we didn't necessarily have problems with the bands per se, but the thing is that over time people would end up having issues with their band. The band would slip, the band would erode, and we'll talk about what those are later, and invariably little things would continue going on with your band until eventually we would take them out. We're taking out more bands and we're putting them in and converting them to one of the other operations. And almost everybody who's done that, was, I'm like, you know what, this is what I thought the band was going to be like. So it's not for everybody, but where I think there's still a good place for this is for my very young patients, patients who are 18, 19, 20 years old. And the reason for that is right here, because it's reversible. What I don't ever want to see happen to anyone is I do an operation on you that is a permanent operation, but you as a young person may not realize what you're really getting yourself into until 20, 30 years down the road. And by that time, it's too late. There's no going back from your irreversible operation. And so that's why it's important to kind of give you a second chance. And hopefully you never need that second chance, but it's nice to know it's there if that's the case. So again, if you're one of my younger patients that have come to see me, well, we can talk about that as an option for you, okay? So the gastric bypass is the operation we've been doing for long. This has been around since the late 60s, and it's now morphed into the operation that we do today, a combination of laparoscopic and robotic. And so what that really entails is doing an operation that creates a small pouch at the top part of the stomach, and once we've created that pouch, the food has nowhere to go. So what I'm going to do is go down further downstream. I'm going to divide the intestine, bring it up so it has a way out, and then I'll reconnect it back to itself so everything is in continuity. Now, the thing that's neat about this is that we thought for a long time that the size of the pouch was really the most important thing. As it turns out, when I first started doing it, we were making super tiny pouches. And we found is that people still had trouble losing weight sometimes, right? And so what I found is that the size of the pouch is actually less. The more important part is actually the bypass. When you're bypassing a segment of the intestine, namely this portion of the intestine right here, that's where your pancreas, your biliary tract, all these other things come in. That's where a majority of the gut hormones tend to play. When you bypass that segment over here, it resets a lot of that, and very, very quickly will kind of get you back to a more normal setting. And that's what we actually find that's where it works. So food's coming down this way, you're still making bile, you're still making acid, you're still making all these things. It just digests starting 2 feet further downstream. So you're still making all those things that you need, you're just letting it absorb further downstream like we talked about. Now, the fact that we're bypassing this and the fact that it's so potent, that's why what we see, this is an incredibly effective operation for diabetic patients. When we bypass this segment of the intestine over there, a lot of times our patients will be non-diabetic by the time they leave the hospital. So you can see it's really, really effective. Now, the flip side of that, well, is that a normal way to be hooked up? The answer is no. This is completely unnatural, but at the same time, it's effective. Now, think about it this way. The more I start messing with nature, the more she starts messing back with you. So yes, it's also an effective operation, but this also is going to have a lot more long-term problems. And I always look at things in terms of the short and the long term. I don't want to hurt you tomorrow trying to help you today. So again, does that mean that a bypass is you lose more weight with it, the weight stays off for longer? Those are true in general. However, that doesn't mean that it's right for everybody. Again, that's the whole rest of your life you're going to be hooked up like this. So would this be fair to do something like this in somebody who's really young? Well, you got the whole rest of your life, 30, 40, 50 years, to be worried about being hooked up like this. No, not necessarily. So where do I think that the bypass has the best use? Well, I think it has more effectiveness and function for patients who are older, right? Patients who have bad diabetes, bad high blood pressure, you're on 20 medications a day. Well, the weight loss is faster, the weight loss is more dramatic, But the thing is, you're also not able to go to the gym. You're also not able to do the same kinds of things a 20 or 30-year-old would be able to do. You need that help right now. You need that more dramatic weight loss. You need to be able to do those things. And you're more likely to understand that whatever problems are going to develop in 15, 20 years, well, if you're older, something else is probably going to get you in that time, as opposed to having to worry about these problems. So you have less time to worry about some of those long-term issues versus somebody who's in their 20s or 30s, they got the whole rest of their life. For instance, like you'll never be able to see this part of your stomach again. If you have a tumor there or something like that, if we put a scope down there, that's where it goes. It doesn't go back. There is a couple places that can actually go back and look, but again, if you don't have a reason to look, why would you? So again, there's a lot of things that have downsides associated with this, but we'll talk about some of the other ones going forward. This is also considered a permanent operation. So again, I've reversed these on several occasions, and it's an operation I never really care to do again, but at the same time, it's very difficult, and more importantly, when you do reverse them, things don't always work quite the way they're supposed to do. So again, this is the gastric bypass, and again, best weight loss with this, long-term, keeping it off, but again, more complications, okay? So the operation that's really gained a lot of traction in the last few years is the gastric sleeve, right? This is an operation that's also I look at it as the Goldilocks operation. It's not too soft like the gastric band, and it's not too hard like a gastric bypass or a switch. It's kind of right in between. So the way this operation works, when you look at the outside part of the stomach over here, right over here is a portion that makes the hormone ghrelin that makes you hungry, right? So what we're doing with this surgery, we're removing this stretchy portion of the stomach that can swell up to about the size of a gallon, to leaving it to where it's a lot more rigid. And so we're basically less hungry, you fit less food. The size of that stomach now is roughly the size of a large banana. You fit less food, and interestingly, it works the third way, which we weren't really expecting. That part of the stomach that we're dividing is actually going to be removed completely from the body. So as you've guessed, yes, this is also considered a permanent operation. That stomach isn't going to grow back. Can't stretch, and we'll talk about that later. But the important thing is it's not going to grow back. This is not a reversible operation by any stretch of the imagination. So anywhere between 50 to 80% of the stomach is removed, but we're not rearranging anything. That's the other thing that's nice about it. Now, after this portion of the stomach is gone, you think, okay, great, you're less hungry, you're fitting less food, that's it, right? So one of the things that we found that was extremely interesting from research after we started been doing this for a few years, what we found is that the stomach actually empties faster after a gastric sleeve. So, well, how does that matter? Well, remember I told you when you do a bypass, you're bypassing the segment of the intestine. Well, when the food goes through here faster, you have less time to interact with that mucosa, with the lining of the intestine, than as you would if things were working the normal way. So what that does is it almost has a gastric bypass-like effect. What we find is that the effect on diabetes, the effect on some of the other metabolic issues are actually way more than we would expect by just making you eat less food. So that's why this is considered a more effective operation than something like lapping. Okay, but again, this part of your stomach, it's a irreversible operation, but we haven't burned any bridges, believe it or not. We still have ways around it should the need arise. But again, this is still considered, this is still hands down the probably the most safe long-term operation, which is one of the things I like about it, is that the long-term side effects are actually pretty minimal. Certain things can occur, but those are usually amenable to repair if there's an issue going on, or it can be converted to something else if need be. We haven't used up all the arrows in our quiver by doing the sleeve first. Now, not everybody's a candidate for this operation either, which is why I'm trying to give you all this information now, so that when you do have your consultation with me, I can go over your specific questions at that time. Okay. So another operation is the duodenal switch. This is an operation I'm not going to talk too much about because it's an operation I will not perform. This is an operation that's been around for a long time. And remember I told you with the gastric bypass we're bypassing some of the intestine. Well, with the gastric bypass, we're only bypassing about 2 feet of your intestine. With this operation, the intestines are divided. You only got about 2 feet left. So what's happening is, yeah, it's a great operation for losing weight. Unfortunately, it's also a great operation for you're not absorbing your calories, so you can eat quite a bit, but you're also not absorbing a lot of the things that you need. So there was a surgeon in Delano who was doing a ton of these for a long time, and his tagline was, "Oh yeah, you can eat what you want and still lose weight." Is that the message we need to be giving our patients? Of course not. No, and I've seen a few people actually eat through this operation, which is pretty amazing. But the point is that nothing is going to change if you don't change it yourself. But the important thing is this: is that now that you've got such a shortened piece of intestine left to do all the absorption, the risks associated with that go way up. The vitamin and mineral deficiencies are through the roof. So yeah, you're off your diabetes medicines, you're off all this other stuff because you lost the weight, but now you're probably spending more money in vitamins and minerals than you did ever in your prescription. So did you really help yourself? Plus, that weight loss is very unnatural, and so basically patients end up having this kind of sallow, almost sickly look. The other thing also is that remember I told you fat is very hard to absorb? Well, you can't absorb your fat in 2 feet of intestine. It's actually very hard. It takes a lot of work to be able to do that. So the other thing also ends up happening is anywhere between 6 to 12 loose, foul-smelling, fatty diarrheas a day, which again doesn't seem like a big deal, but you know what? It leads to a body odor, and you're constantly gassy, and it is very foul smelling. It may not seem, it seems kind of funny, but the thing is, if you didn't know that that was an option, or that was a side effect, and you got one of these permanent operations, and then next thing you know, you pass gas at work, nobody's gonna want to sit next to you. How imagine being intimate with somebody and having that body odor? It's very, very, very effective on your personal life. You don't realize these side effects can really affect you the way that they can. And again, that's why I think that the things that you gain from this operation are far less than the risks you take, both short and long term, because it's a big operation. Again, this is a totally unnatural way to be hooked up. And you have to ask yourself, is losing the weight actually going to make you healthy, or is being healthy going to make you healthy? Yeah, you'll lose a ton of weight with this most likely, but at the same time, are you actually any healthier? And in general, my answer to that is no. So the Revera gastric balloon is something we're not doing right this minute, but this is a balloon for those of you who don't quite meet criteria for weight loss, or just absolutely just like, no, I don't ever want to have surgery. This is put in endoscopically. It's a balloon that goes in on the top part of your stomach over here and fills that top part up, so that when food comes out, it fills that up, so basically you feel full. And so that's designed to sit in there for about 6 months, and then what happens is that I go back in there with an endoscope, and I can deflate that balloon and then end up pulling it back out. So that, interestingly, after that balloon comes out, it still ends up, your body ends up still thinking that the balloon is in there. So the effect seems to last for a couple of years, not just during the time that that balloon is in there. Now the reason it's also not going to be as effective as one of the weight loss surgeries. You can expect about 30% of the excess body weight coming off. Now right now, because it's not geared for patients who are sicker with diabetes, high blood pressure, or meet criteria for weight reduction surgery, that's not really who this is for. So somebody who's 30, 40 pounds overweight wants to be able to get that off. For instance, you want to lose 30 pounds before your wedding. Okay, well, this is probably not a bad idea to be able to do something like that. You take it out a week before the wedding, and you can go on and carry on, and you'll be fine. Now, the reason I've kind of stopped doing this for a minute is because of right here. It has to be removed in 6 months. I think the FDA at some point is going to increase that to a year. They haven't done so yet. But the thing is, I don't want to go in there and take it out in 6 months, and all of a sudden, the next day the FDA says, oh no, you can just leave it in there for a year. You're going to be very upset with me. Especially since most of the insurances will not pay for this. This usually ends up being a cash procedure. If there's something you're interested, we can talk about that at a later time. But for now, just know it's out there. If you or somebody else is interested in doing something like that, we can talk about that when the time comes. So looking at the weight loss results, looking at the Lap-Band at 2 years out, usually about 50% excess body weight loss is what we can expect. The gastric sleeve and the gastric bypass, the weight loss is going to be a little more rapid and a little more dramatic, with usually things leveling off at about 12 to 18 months, and about 24 months you're right about there. When you look at the gastric bypass and the gastric sleeve at 2 years out, usually people are about 10% off from one or the other, which means the gastric bypass is going to have lost about 10% more. For most people, it ends up being about 10, 15 pounds, somewhere in that range. So you have to ask yourself, that 10, 15 pounds worth all that extra surgery? And that's a question only you can answer. So as long as you're willing to put in the work for it, then that extra 10, 15 pounds you can get off with the sleeve just as easily. Okay. So risks and complications. There is no such thing as risk-free surgery. Okay. I'm going to try to do my best to kind of keep our risks to a bare minimum, but nonetheless, everything has risks. So when you look, I divide them into short-term problems and long-term problems. For the short term, anytime I'm cutting something or stapling something or dividing something and putting it back together, then there's always a chance that it can leak. I'm a very paranoid surgeon, but I can never put things together as well as nature had in the first place. When you're looking at the gastric sleeve, this top part over here can end up having a little disruption over here. And when you look at the gastric bypass, there's actually 5 places you can leak. this connection, this line, this line, this line, and this connection over here. Any one of those can leak. But what happens if you leak? You're going to get sick. We're going to know there's a problem. And there's things we can usually do to help temporize them. Occasionally means going back to surgery. Occasionally it just means doing other procedures to kind of help guide you through it. Almost always these will take care of themselves. You just have to be patient. Sometimes it'll take several months to be able to do that. But most people, after these leaks have closed, usually go right back to the normal weight loss parameters. So again, we try to do everything we can to minimize that. Overall, the risk of a leak is going to be about 1 to 3% taking out all comers. Okay. Remember we talked about blood clots, deep venous thrombosis. Those are the blood clots that happen in the legs and thighs and goes to your lungs. It's called a pulmonary embolus. This is the #1 killer after weight loss surgery. It is also one of the #1 killers after any kind of surgery when you're talking about morbidly obese patients. What happens, especially when you've got all the extra weight on the legs and thighs, especially when you're dead weight during surgery, it collapses those veins and now blood can't get through very easily. It forms a little clot. That clot can propagate. If it's a big enough clot, it'll break off chunks and it can go up through there, flip around your heart, and end up lodging in your lungs. If it's a big enough blood clot, it can kill you. And that's why we get so bent out of shape about it. So there's a couple things we can do to try to help minimize that happening. #1, I want you up and walking around as much as we can right after surgery, as soon as you're stable on your feet. #2, lose as much weight as you can before surgery, because the more pressure there is on the legs and thighs, the harder it is for the blood to get through. And we'll talk about that a little bit going forward. And then the third thing is, if you've ever had surgery before, a lot of times they'll put these pumps that go on your calves. We have access now to some of those pumps to be able for you to be able to take home. Most of the insurances will pay for it. A lot of the HMOs will not. It's a nominal amount, and that's something that if we can try to diminish your risk even further, because the way I look at it, one of these blood clots is blood and blood clot too many. I don't want you to go through all the work getting that weight off, being prepared for surgery, and then all of a sudden something crazy like this gets you. So we want to do everything we can to mitigate that risk. Doing everything we can, that risk is going to be less than 1% having a deadly blood clot. Okay. So bleeding is a possibility with any surgery, but again, the chance of bleeding to the point where I would need to give you a blood transfusion or something like that is less than 1%. Obstruction usually ends up happening from swelling right after surgery, and that swelling usually does take care of itself over time. Conversion to an open procedure, or having to open you up, I reserve that right for anybody if there's something going on that I don't feel that I can safely take care of with the scope. It's extremely rare to ever have to see something like that. Chance of you having to be open is way less than 1%, but it's never going to be 0, and I will always reserve that if I think it's safest for you. Okay. Some of the long-term risks: gastroesophageal reflux. How many heartburn sufferers are there? There's probably a bunch of you. And so let me talk about that for just a minute. Well, heartburn is fundamentally caused by one thing, and that is what's known as a hiatal hernia. For those of you who know what a hiatal hernia is, this will make sense. If you don't, I'm going to explain to you. A hernia is basically a hole that allows things to go from where they belong to where they don't belong. When you look at the esophagus, it comes through the chest, and there's a little opening in the diaphragm muscle. That's the breathing muscle that separates your chest from your abdomen. There's a little tiny snug little opening around there that allows it to go through. So there's a couple centimeters of esophagus there in your abdomen, and then at the end of the esophagus is a little flapper valve that prevents acid from going up into your chest, and everything works great. So like I said, the hernia happens when this opening ends up getting bigger. That ends up forming a hole that doesn't belong there. Now when you breathe, when that diaphragm pushes down, it creates a vacuum in your chest. What do vacuums do? Well, they suck. It's like opening up a bellows, sucking the air into that, right? So what happens is you're now sucking air into your lungs. Well, now you've got a negative pressure environment. You're also sucking your stomach up into your chest. When that happens, you're in a constantly negative state over here. There's a negative pressure there. It basically acts like a siphon. You're siphoning up gas. You're siphoning up acid up into your chest. That valve, which is supposed to work where it's supposed to, now is in the wrong position. There's nothing to stop it from going directly up into your esophagus. And that's when people get heartburn. You can get acid reflux. You can get stuff regurgitated into your lungs. It can cause new onset asthma, dental caries, and back. It's actually really bad. And more importantly, it can lead to something called Barrett's esophagus, which ends up being a precancerous condition. Right now, esophageal cancer is one of the fastest growing cancers in the country, and I think it's because we're seeing more and more of this reflux. Now, this is an example of what that looks like. So this is a lady whose gallbladder I took out. She goes, yeah, I have real bad heartburn. So when I took her gallbladder, I took a look under her liver. Look at the size of that hole. All this stomach was stuck up in her chest. And of course, needless to say, there's no way things can work right when it's all packed up into the chest like that. And eventually I'm going to let go of that stomach. You see it go snap right back up into there. You can see the size of that opening over there. So there's no way things can work when they're not in the right position. The good news about that is that I can actually go ahead and repair that hernia at the time of surgery. And so basically once that hernia gets repaired, then that heartburn problem goes away. And I can't tell you how many people told me, I was like, hey doc, I don't care if I lose any weight, my heartburn's gone, it's worth it right there. So I had a hiatal hernia. I had mine repaired a few months ago, and it's the best thing I ever did. So did my 8-year-old dad, and he didn't realize how bad his heartburn was bothering him until he stopped doing that. And I do a procedure called a Lynx procedure. So those of you who are just suffering from heartburn, you know somebody who's having significant heartburn, there's something you can do about it. Those medications that we put you on, the FDA said you're only supposed to be on those medications for 8 weeks, and yet we've got people that have on them for 20 years. And again, we're looking at the effect. Yeah, hey, I'm not heartburning anymore. Yeah, but you're still refluxing. You're just not feeling it, because now you're refluxing, you're just not refluxing acid. Well, that stuff's still regurgitating, you're still getting it into your lungs and still causing damage, right? The other thing also is those pills, what we're starting to realize is that now we're seeing them for so long, starting to see memory problems, dementia, Alzheimer's, bone problems. We're also starting to see kidney issues, changes in your gut flora. This is not a benign medication. And so, like I said, rather than fixing the symptom, the heartburn, let's just fix the problem. It doesn't make sense to do it the other way around. So again, the nice thing again, we can do something about this at the time of the surgery. Okay, so vitamin deficiencies. When you talk about a gastric bypass, remember that I've told you that first part of the intestine that we're bypassing, there's 3 things that are best absorbed there. Vitamin B12, iron, and calcium are best absorbed in that first part of the intestine. Now that doesn't mean you're not going to absorb them, it just means they're best absorbed there. So what it means is that you're going to have to supplement that for the rest of your life. As long as you're hooked up that way, you're going to need to do that. Okay, and that's something that even if you're doing by the right amounts, and we're going to check you for that, we'll still check for blood levels and make sure that we're doing everything we can to make sure you're on top of that. The sleeve can very rarely lead to B1 deficiency, which can be very hard to treat. But the thing is it's super easy to prevent. Just take your B1, you'll pee out what you don't use, and you'll do just fine. The duodenal switch patients, again, like I said, that's not an operation I do. The list is literally pages long. And again, you gotta ask yourself, is it really worth it? And in my opinion, it's not. Okay, so for the vitamin issues, there's, most of those vitamins actually don't taste very good or whatever. So we've actually taken the time to kind of look at, figure out, number one, which are the ones that are going to taste the best, because if they don't taste good, you're not going to take them and you're going to wind up in trouble. So we look at it in terms of patient compliance and looking for the ones that do well from there, and also the most cost effective, ones that are specially made for our bariatric patients to help with their absorption and that sort of thing. And again, we'll set you up with which of those we can, so that way you have what you need. And the same thing also applies for your protein supplements. So again, we have a few options for you, so that way we can set you up for those, so that we have all the tools that you need to be successful with this going down the road. Okay, so some of the other long-term issues, this is specifically for a gastric bypass, ulcers. This part of the intestine was never meant to see acid, so even the little bit of acid made by this little part of the stomach over here is enough to cause ulcers, especially in the face of 3 things. Number 1, alcohol. Number 2, cigarette smoking. And more importantly, number 3 are non-steroidal anti-inflammatory drugs. That's like ibuprofen, Aleve, naproxen, same idea, aspirin, meloxicam. These are all drugs that people use a lot for fever, a lot of times for aches and pains, arthritis. If you're dependent on those medications, you can't have those after a gastric bypass, because the incidence of developing ulcers is extremely high. So if that's something you're dependent on, that's a conversation to have, then this may not be the right operation for you. Other thing also is stenosis. And what that is that where the connection between the stomach and the intestine over here gets really scarred down, it comes really tight, like I can't swallow, everything keeps getting stuck. And so the treatment that's fairly simple, I can go down there with a balloon, I can gently stretch that open. But in all defense, I make that opening tight to begin with. And the reason for that is when you look at people who've had gastric bypass over the years and they've gained their weight back, almost invariably every single one of them says, I can just eat all day, I never feel full, and can just graze. And when I put a scope down them, I can see that this opening is wide open. Food just goes whoop, it never fills up that stomach. They never feel that fullness, so they can just eat all day. And so what I do is and it's very hard to make that smaller. You have to basically redo the operation, which a lot of times if your pouch is really small, there's no room for that to work, and it makes it really challenging. So I tend to make mine on the smaller side. I cheat on the side that's easier to fix. It's a lot easier for me to gently make it a little bit bigger so you still hang up a little bit, still feel full, as opposed to being so big things just fly right down. Okay, and an internal hernia is the final one. If you look on this depiction, there's some spaces over there, right? Well, that space is a real gap that we create when we're bringing the stomach, the intestine up there. The mesentery, or the sheet that where the blood vessels to the intestine live, I have to make a little division in there, and I can swing it up. There's a little gap in there. I close those holes up during the time of the surgery, but sometimes with rapid weight loss, the fat ends up becoming really weak, and it can just tear through, and then it can redevelop a hole there. If that happens, if it's a big enough hole, the other intestines can flop through there, it can twist around and get caught. And if it's a big enough hole, if it's enough stuff gets through, it can cut off its own blood supply, and you can wind up in real trouble. Which is one of the reasons why it's super important to keep me in the loop whenever you have a bypass or any other weight loss surgery, because again, we're looking for this kind of problem. And again, this doesn't happen like this. This is a gradual thing. You'll have this kind of vague pains and that sort of thing. And I'm looking for this all the time. So if I'm concerned this may be the problem, then we can nip it in the bud when it's just intermittently happening. I can go in there, and I can go there with laparoscope even and close that hole up. As opposed to if this just keeps going, you know, your primary care doctor, your GI doctor may not be looking for this. The next thing I know, your intestines are already dead. Now we've got a big problem on our hands. So again, always keep me in the loop, because like I said, I take ownership of my patients. If you're my patient, you're going to be my patient forever. I'm going to make sure that I do everything I can to watch over you. Chance of an internal hernia happening after gastric bypass is about 1% per year after having had a bypass. Okay, so other things also that can happen, especially with the gastric band, are slips and erosions. When you saw the pictures over there on the band, you saw it just sitting on the stomach. Well, actually what I do is I wrap the stomach over and I put stitches in it, and I kind of lock it in place. If you're vomiting excessively, things get caught in there, you know, your stomach wrenches very hard, you can break those stitches. Now the stomach can squirt up underneath there, and it comes really, really tight because you got all this stuff bunched up under that band. And in the old days, I used to just deflate your band and see if it worked. If it didn't work, I'd go back into surgery, I'd pull everything back down and re-stitch it back in place. That almost invariably never worked. Within 6 months, people end up slipping again. And once it slips, it becomes very hard to get you to the proper place for proper adjustment. So nowadays when people slip, I just go ahead and take the band off. I let everything heal for about 6 months. And after everything is healed, we can convert you to a sleeve or a bypass or some other operation, depending on what the situation is. Erosions happen usually, we saw this a lot from the Mexican bands because their technique was a little bit different. It's a lot rougher on the stomach. You get a little damage to the stomach. Now the band, just from the pressure of it, ends up sawing its way through the stomach, and it heals over it over time. So eventually what ends up happening is that your band, when I look in with a camera and I flip up the camera and I start looking up, there's the band sitting inside the stomach. That's like me wearing a belt that goes through my belly and out the back instead of around my waist. Again, this is a very hard problem to deal with. You just got to take the band off and try to close the hole as best you can. This has to come out. Chance of that happening is it's less than 1%. And knock on wood, I haven't had that happen to any of my bands that I know about, but nonetheless, I've seen a lot of these happen, and I've fixed that problem. But it's pretty uncommon, but it's still there. Okay. Other things also are gallstones. We talked about that briefly. If you've already had your gallbladder out, you don't have to worry about it. If we're going to check you to see if you have gallstones at the time of surgery, as it turns out, if you do have gallstones, I can take out your gallbladder at the same time. If you don't, if there's nothing wrong with your gallbladder, there's no reason for me to take it out. However, there is about a 30% chance of developing gallstones within the first 6 months to a year after having weight loss surgery. So again, one of the reasons why I want to make sure I follow up with you, because if you're having some of these symptoms, we can just get an ultrasound, and it's a lot easier to go and take out your gallbladder later. But at the same time, hopefully you won't need to. It's a 70% chance you may not develop that problem. And then the other thing also is NSAIDs. We just talked about that. That's ibuprofen, naproxen, meloxicam. Big no-no after a gastric bypass. Okay. Weight regain. Almost every single person, when you look at how or why the patients regain their weight after weight loss surgery, almost always it's because they've gone back to their previous lifestyle habits. And that's why I tell you the surgery is never really here. The surgery's here. And as long as you're willing to make those changes and work with us on that, then the chance you gain your weight back is very, very small. Now, sometimes there is a technical problem. For instance, like I told you, that opening is really big and food doesn't go through. If you're seeing me for a revision, that doesn't mean that say, oh no, you're just eating badly. No, there's a lot of things we can do. I'm gonna re-examine you, and I'm gonna make sure that we test you thoroughly to look for some of those technical problems that could be causing that. And whatever part of it we can fix, we're certainly gonna address that. So every revision operation I take on an individual case-by-case basis because everybody's situation is a little bit different. So we'll take that as it comes along. Okay, so looking at the overall results and looking at the resolution of some of these comorbidities at about a year, 80% of diabetes and high blood pressure completely gone. For those of you who have sleep apnea, kiss your CPAP goodbye. 86% of those patients are completely resolved. Hyperlipidemia or cholesterol problems, about half. That number, remember I told you, half of that is actually still part of your genetics, but the rest of them do see some improvement. Now this is resolution, that means it's gone completely, okay? The rest of those people, almost all of them, will have some improvement regardless. If you're on 5 pills, now maybe you're on 1. That's not resolution, but it's still a marked improvement. The other thing also that's interesting on this particular graph, this isn't my data, this is a published study, 33% improvement in heartburn. Well, my numbers are probably closer to about 95%. The reason is because I'm very, very aggressive about identifying and fixing that hiatal hernia, especially after a gastric sleeve. Because one of the things you may read on the internet, people say, oh, well, sleeves are bad because you end up getting heartburn. Well, almost always it's because the surgeon may not be as aggressive about fixing those hernias. And again, once you fix that hernia, almost always patients say, like, oh, heartburn's gone. It's very, very rare to ever see that kind of thing happen. So don't let that be the thing that determines your decision. Okay. Now remember that metabolic set I told you, the thing that just doesn't change, it takes years and years to move. You can move it up, you can move it down. The gastric bypass and the gastric sleeve, remember I told you how it affects that first part of the intestine over there. That changes the metabolic set point almost immediately. Now, it's not going to bring it down to where your ideal body weight is. None of these operations are designed to get you to your ideal body weight. They're designed to get you to a healthier body weight. So whatever that new set point is, over time it'll work to get you down to where that set point is going to be. Now, over time, what happens at set point? If you keep working at eating right and making sure that you're exercising and doing the things that you need to, well, guess what? You can keep creeping that set point down. On the other hand, if you're kind of going back to where you were before, that set point can start going up again. And again, if it just let it go completely out of control, you may even wind up at the same weight you were at before surgery. We never want to see that happen. We want to use this second chance, this very powerful tool, to get that set point down and really use that aggressively. Okay. Overall results. Improved life expectancy, that 10 to 15 years off your life, you get it back. Overall, people will tell you they are a new person, right? Health, work, and social interactions, all these things. When a successful operation happens, they will tell you, it's like, oh my God, I didn't know I could feel this good. It's very, very common to hear that, right? So what can you do to prepare for surgery? If you're a smoker, that's something we're going to need to work on, because smoking will increase your risk of the blood clots 800%. It'll increase your risk of a leak happening to 10% from 1 or 2%. It's just bad for your risk of pneumonia, all these other things. It's bad enough that we will use that as a reason, saying, hey, you're not quite ready for surgery yet. That doesn't mean that you don't, say, oh, you'll never have surgery. No, no, no. No, we want to help you quit. Do the thing that's killing you faster than your weight. And so start talking to your primary care doctor, start making sure that you start talking to people around and say, hey, look, I need to quit this. And think about all the money you're wasting also. Doing all those things, we can do that. Now we'll check nicotine levels. I want to make sure there's 3 negative nicotine levels before we think about doing surgery. And so I've actually had to cancel people on the day of surgery because of a positive nicotine level. It's like, hey, I thought you quit. And they're like, well, it was just 1 cigarette. I'm like, well, then you're not quitting. You haven't quit. So let's just get you where you need to be. And sometimes people get upset with me, because I'm very strict about that. But the reason I'm strict about that is because I'm protecting you. Somebody who willy-nilly wants to just operate on you regardless of that doesn't have your best interest at heart. I'm willing to wait. It's okay. I'm not going anyplace. I want to make sure we do this when the conditions are right so that you understand what you need to do. But more importantly, I don't want to get you in trouble doing an operation trying to help you. That's the important part. Start eliminating carbonated drinks. The bubbles aren't good. It's going to stretch your pouch out. Caffeine and alcohol. One of the things we really got to watch out for is especially right away at the beginning of the surgery, easy to get dehydrated. Both of those are diuretics. They're going to make you pee out your fluid, so it's very hard to stay hydrated. Now, at the same time, I'm not going to begrudge you your cup of coffee in the morning, but if your cup of coffee is this big, we got to make some changes, right? The other thing also about alcohol is that when you take away somebody's food addiction or their dependence on food for various things, you oftentimes will find other things to become dependent on. Now, it's very common for people to have other maladaptive behaviors. Suddenly develop gambling addiction, sex addiction, shoplifting. Number 1, alcohol abuse. And that's why we tell you just stay away from alcohol for that first year until you really know how to work with your surgery. More importantly though, let's make sure you're open and honest with the psychologist when they talk to you and say, look, I've got these issues, these are things we need to deal with. I want you to have a healthy coping system. I want you to have a healthy support network so that way you don't fall into other dependencies as part of your recovery process. We want to make sure that you find healthier ways of being able to do it, and that's something we can help you with there. If you're not exercising, let's get you on an exercise program. For those of you who have bad hips, bad knees, and you can't really go out to the treadmill and run for 10 hours, the thing is that let's get you to a swimming pool, because if your hips are bad, your knees are bad, you're in a wheelchair, you're on a walker, the pool will take all that weight off your back, your knees, your hips, your ankles, so that way you can actually be much more aggressive about being able to do that. For those of you who don't have a gym membership that has a pool, the north of the river pool right here on the River Lakes in Meany, it's not too far from over here. It's $2 to get in. You can go there as much as you want, and basically that'll allow you to be able to do that. I don't know if they're open right now, but with all that's going on, but when the time comes, you can actually use them. Start reducing your carbohydrate intake, like we talked about. Start using the Calorie King thing. Start reading those books that I showed you earlier. Make sure you're doing what you can from that. Start preparing yourself in that way. When the time comes, we'll have you start your vitamin mineral supplementation. There's a pre-op support group that's going to go over a lot of the things you need to do to be successful with that. And we'll give you a roadmap, and we're going to have you follow it. And quite honestly, we're going to make it as easy as possible for you. It includes learning how to eat and drink. And you're like, oh, I know how to eat and drink. Well, the rules are a little different after surgery. We're going to guide you as to what the best options there are. Talk to your primary care physician, because your primary care physician is going to need to be able to follow up with you and be able to write you that letter. More importantly, most of the insurances are going to require you to follow up with your primary care physician for usually about 3 to 6 months, depending on what the insurance is. And that means going to your primary care physician, they document your weight, they document that they talk to you about your weight, and they've got a treatment plan for that. So usually it's 3 to 6 consecutive months, right? Mostly it's 6. And that means if you've gone every month for the last 5 months and all of a sudden you missed a month, the clock starts over. So start making those appointments now with your primary care doctor, so that way you don't have to worry about doing it. And also do it at the beginning of the month. Make your appointments for the beginning of the month. So that way, say your doctor gets a flat tire, or you get sick, or whatever the case might be, and you can't make it that week. Well, the next time they see you is the next month. Well, you still have a few weeks if it's the beginning of the month to be able to get in there, because they go by the calendar month, not by the number of days. So if you see somebody on the 29th and you see them again on the 1st of the next month, they count it as 2 months as opposed to 3 days. Okay? So don't let the system game you when it comes to something like that, and we'll guide you on that process as well. The other thing also I'm going to want all of my patients to be able to do is be able to lose weight before surgery. We're going to show you exactly how that is. That exact number, how much I'm going to want you to lose, is going to be given to you at the time of your consultation. And so most people, it ends up being about 10% of your excess body weight. So for 100 pounds overweight, that's 10 pounds. But I'll never get upset with you for losing more weight than I asked you to. There's a couple of reasons for that. Number one, it tells me you're ready. You can follow a program. You know what's necessary to be able to do that. Because if you can't make those changes now, how are you going to be able to make those changes after surgery? That's when we see people who are not doing well after surgery. A lot of times they weren't really shown how to make these changes. And that's why I wanted you to be able to see, it's like, yeah, hey, you know what, I get it, right? And people who, and what I'm seeing in my own experience is that the patients who are able to do really well with the weight loss before surgery tend to continue to get that weight off and do better after surgery. So really, let's get you where you need to be from that. The second thing also is for your safety. Now, you've seen all these pictures of these surgeries where the liver's nice and up and out of the way like that. Well, that's not really how it is. The liver's actually sitting on top of everything. One of the things that happens as you gain weight is you don't just gain weight underneath your skin, you're gaining it in your organs. And a fatty liver is one of the things that you can really develop as a result of this. And this isn't, it might be a little too bright or whatever, but the point is, this is the liver sitting, you can see just barely this bottom strip of the stomach right over here. I'm trying to lift this thing up. You try to lift this thing up, you're gonna crack that liver, and it's impossible to see what I'm doing. How am I supposed to do a safe operation on you if I can't even see what I'm doing? So losing that weight, we're gonna show you exactly how to do it. We've got a whole prescription ready for that. And so, not necessarily pills, but I mean, we're gonna prescribe how to do that at the time. And then that's designed specifically to shrink all the fat out of that liver in that little 2-week window before surgery, so that way we can get this out of the way and I can see what I'm doing, and you have a safer operation. And that's really what it's designed to do. But again, we'll give you the details of that when the time comes, and make sure that we get the weight off before surgery. Okay, insurance coverage, we try to be contracted fairly with all the insurances possible. However, every now and then there's an insurance that I'm not contracted with. And don't let that bother you, because you're like, oh my God, I'm going to have a massive copay, or I'm going to have a massive co-insurance. That's not necessarily true. If I have a problem with your insurance, then that's between me and the insurance. It's not your problem to deal with. So usually what we will do is we will actually respect the in-network rates for you if you're an out-of-network patient. So basically, if you're not out of network with me, what you pay in network is what you'll pay with me. You're not going to have to worry about that, and we're not going to have balance bill that or anything like that. So you don't have to worry. It's not going to cost you more to see me just because I'm out of network. So don't let that bother you. But we'll go ahead and run your insurance, and we'll figure out what your eligibilities are and let you know all the financial aspects of it right up front. No surprises, nothing funny like that. And then we'll make sure you understand exactly what is necessary for you. We are not contracted with Medicare. That doesn't mean we can't see you. It just means we have to do things a little bit differently. There may be a little bit of a prepayment that's required, but then once that happens, and that usually will take care of it. That covers you for the first year afterwards. Okay. And the intragastric balloon or the Orbera balloon that we talked about, like I said, is not covered by insurance. And again, financing is available for all these things depending on what the situation is. Okay, so in summary, obesity is a growing problem not only in the United States but also around the world. The treatment is lifestyle change, where surgery is only a tool that, when used properly, is going to get the weight off, and it's going to help you keep it off for the rest of your life. Now, the word easy never really came out of my mouth during the course of this talk, but the point is that when you put in the work and you really understand what needs to happen, the rewards are going to last you a lifetime. So it's really important you do that. All right, so Lucia, you've probably had a bunch of questions coming through. Hopefully, what's that? Oh, you answered the majority of them. Okay, well, that's great as we come along. One of the other things, do you get anything about weight, skin or anything? No skin questions. We usually get a lot of skin questions. So what happens to the excess skin after surgery? Well, usually I'll tell you be patient with that. We want to make sure you've got as much weight off as you can before we think about removing some of that excess skin. And so I usually will try to work with the insurance to try to get that skin surgery covered. And I will usually be able to take care of the apron or the belly fat, and sometimes the arms as well, depending on how that goes. Anything more complicated, a breast lift or full body lifting like that, we do work with some of the plastic surgeons in the area that can hopefully help do that. Hair loss, any hair loss questions? Excuse me. Choking on my spit. Don't have COVID-19, don't worry. The other thing also is hair loss is very common after these kinds of operations. That's just a natural part of losing weight rapidly. That's why we tell you stay on top of your vitamins and your protein. That will limit how much weight you lose. It tends to start between 3 to 6 months after surgery, during the height of the weight loss. It tends to last for about 6 to 9 months, and then it stops, and your hair will come back. So don't worry, you're not going to go bald. If you're already bald before the surgery, it ain't going to make your hair grow back, I promise you. So that's just something to bear in mind from there.
Follow us on Instagram.
Huh?
Instagram, follow us
Oh
on
yeah. So we tend to put up a lot of good articles and posts on both our Facebook and Instagram pages. So if you get a chance, follow us on Instagram, and I think it's NL Medical, NL_Medical on Instagram, and it's New Life Medical on Facebook. You can. We're going to be a little better about putting more videos on YouTube. We've been a little slow about that. And a couple of my videos, actually a lot of them, got taken down for unlicensed music, so I have to be better about getting better music on there. But that's fine. So we're going to be putting up surgery videos and that sort of things now here shortly, so that way you have a good idea of exactly what sorts of things to look out for. So if you got any more questions. Oh.
Will starting the vitamins pre-surgery help negate some of the hair loss?
So the question is, will starting the vitamins before surgery negate some of the hair loss? It may not necessarily negate it, but it can temporize it. So hopefully it's not going to be as bad as if you didn't have it at all. So if it's going to happen, it's going to happen. What we want to do is try to minimize that. So again, taking the vitamins, again, we'll guide you through that process, and making sure you're up on your protein are the two best things you can do to help minimize it. Maybe not necessarily make it stop completely. All right. Well, I want to thank everybody for their attention, and we look forward to seeing you in the office. And again, right now, as it stands, our office is open, and we will be seeing patients, and we'll try to get you scheduled as quickly as possible. So if you can, please contact Lucia at info@newlifemedical.com, and then what we will do is we'll be able to go ahead and get your insurance verifications taken care of and get you set up then for your appointments as soon as possible. And again, hopefully you found this informative, and if any other questions develop, develop. Again, feel free to email us if necessary, and otherwise I'll be happy to answer those questions for you in person. Okay? All right. I thank everybody for your time and attention, and look forward to seeing you in the office. Remember to follow us and answer any questions if we have. All right. Thank you very much.